Hello and welcome to the second of our three-part video series on using the ultrasound to assess knee osteoarthritis. In this video, we're going to discuss the basics of musculoskeletal ultrasonography, or MSK for short. Once again, this project was generously supported, I should say, by BD Health and administered by the independent colleges and University of New Jersey. Thank you for your support. Now let's dive in. So this is not exactly the ultrasound we have, but it's by the same company and it looks identical. So close enough. This is from a company called Clarius. And the purpose of this ultrasound is very specifically to be portable. So it's small, it's handheld, it doesn't have any wires. It connects via a wireless internet to any kind of handheld device, an iPad, an iPhone. I believe it works with Android phones as well. And it's designed to be simple. So if you've ever been to a hospital or a clinic and seen the ultrasound they have there, you might have noticed it's very large. It's usually on a cart. It's got a dedicated monitor and it's got this processing unit with a bunch of knobs, and the technician has to know how to adjust all those knobs. This is much simpler than that. And rather than the knobs, you have presets, for am I looking at a knee? Am I looking at a shoulder? Am I looking at a heart? There are ways to go in and make the same adjustments that a technician would make at a cart in a hospital, but you don't have to, which makes it ideal, I think, for people that are just learning the ultrasound. You don't have to worry quite as much about the detailed settings as you do just picking the setting. It's not quite as powerful as the ultrasound you would find in a hospital, but I think it's good though, and the simplicity kind of makes up for it. Makes it a good learning device. Now that being said, it's still going to be useful to understand how fundamentally any ultrasound, including the Clarius one, works in order to understand what you're seeing on the screen. So the way any ultrasound works is you have what's called a transducer. The transducer both creates the ultrasound waves. So when I say ultrasound waves, think sound wave, but at a high enough frequency that they're inaudible to the ear, thus ultrasound. So this transducer produces those waves. Those waves then pass through whatever medium it is that you're scanning until it strikes an object. Then the wave gets reflected back off the object. And then that same transducer that created the wave also receives the signal and turns it back into the electrical signal, which then gets set to your device. And the device interprets those reflections into a two-dimensional black and white image. Now, the significance of the black and white occur, you can kind of think of it as a continuum of echogenicity. So echo, the root word here is echo, right? We're looking at the echoes of ultrasound wave bouncing off objects. So you'll see a lot of words here with this sort of echo, echo, echo in the word. What do they all mean? Well, generally, echogenicity is defined as the ability of a tissue to reflect or transmit ultrasound waves in the context of the surrounding tissue, and how strongly these echoes are reflected back results in some shade of white, gray, or black. So when you have something that's called hyperechoic, it appears white on the screen, and it appears white on the screen because most of the sound waves that hit it are bounced back to so that the transducer can see it. So on this particular image, this is this white line here. This represents the surface of the femur, and you'll notice, right here is extremely bright white. This is very hyperechoic. The surface of bones tend to be very hyperechoic. You'll notice it's slightly less hyperechoic right through here, right? What's going on? Well, the transducer is essentially oriented so that the waves are coming down this way. And so this surface, because of the way it's positioned, bounces the waves straight back. Whereas this surface, ultrasound wave comes in, but then it bounces off this direction. It doesn't come in quite as strong. So it appears slightly less hyperechoic than up here, but it's probably safe to assume that the whole surface is pretty uniform. The opposite end of the spectrum is what's called anechoic, the regions that appear black on the screen. There's two reasons why something might be anechoic. One is that it just might be behind another surface that reflects all of the ultrasound waves. So that's what you see sort of deep to the line that represents the femur. This area down here is femur. But what happens is the surface is so hard that all the ultrasound waves reflect off of the surface and none of them ever reach this region down here. So it is anechoic because no ultrasound waves ever reach it. Now, the other reason something might be anechoic is because the object itself does not reflect sound waves, and that's the case with healthy cartilage. So all through this region, you see it's largely black. That's because the healthy cartilage is mostly water. And so instead of reflecting the ultrasound waves back, it just allows the waves to pass through. You'll also see this with cysts and other just collections of fluid in the body. Anywhere where it's just mostly water, you tend to have anechoic spaces. A little trick I've learned is that if you're not sure if something is cartilage or fluid, push down on the probe. If it flattens out and goes away, it's fluid. If it does not, it's probably cartilage. All the gray in between is what's called hypoechoic. And you'll notice there's no uniform, there's no just this is gray, there's shades of gray, right? So like I said, think of this more like a continuum. Different regions of fat, muscle, tendon, ligament, etc. will reflect the ultrasound waves with different strengths. They're all going to be some version of a gray shade in here. Perhaps the most challenging thing to get the hang of initially when you start using the ultrasound scanner is exactly what am I looking at? And it's helpful to think of it, that image, as always representing a plane, a slice of the object you're looking at. So the 2D image on the screen, that's what this box represents. The top part will always be the superficial objects, right? The tissue that's closest to where the probe is. So skin is always the most superficial. There's usually a small layer of subcutaneous fat, then maybe some muscles and other things. And then as you go down the screen, you get to the deep tissues, usually somewhere bone is usually the deepest thing, at least for the musculoskeletal applications that we're talking about. Now, what left and right on the screen represent depend on how you are holding the probe itself. And there are two common things we'll use. We call them the long axis view and the short axis view. The long axis view, well, there's an indicator light. So the idea here is whichever side of the sensor the indicator light is on is going to appear on the left side of the image. So when we're doing something at a long axis view, typically what you want to do is you hold the probe in such a way that this light is facing proximally. So for scanning a knee, this light is pointed toward the hip. And as a result, the left side of the image will represent the more proximal structures, the right side more distal structures. For example, if you're scanning the suprapatella region just above the knee using the long axis view, then down here on the right side, you'll probably see the patella somewhere up here, the femur deep to that. And then as you move more proximally, you might see things like the quadriceps tendon up here. Then there's what we call the short axis view. And the way I like to do the short axis view is then you rotate the scanner so that the indicator light is facing laterally. And that way, when you look at the image, you still have superficial and deep, just like you did before, but now we're getting a transverse plane slice with the lateral structures on the left side, the medial structures on the right side. And I like to always hold the scanner so that that light faces laterally. So if I'm scanning the left knee, for example, this light will be facing to the left. But if I'm scanning the right knee, this light will be scanning to the right. The reason I like to do that is because then every image looks the same. And you have to be a little careful because there's a way in the images when you save the images to attach labels to it. And so you want to attach a label to indicate, am I looking at the right side or looking at the left side? Because you won't be able to tell from the image anymore. The images will look the same. But I find it easier to interpret the images when they all look the same. I don't have to do the little mental gymnastics of, am I looking at a right or a left side? They're all just going to look the same. The real art of doing this involves what's called the angle of incidence. So this image here represent is a good sort of visual representation of what I mean. So it essentially is, what angle are you holding the sensor relative to the skin? So, and why is this important? Well, in this image, you see, one here is showing you holding the sensor perpendicular to the skin. So this dotted line represents the essentially the plane that you are scanning, but you'll notice the artery doesn't coincide with that plane. It runs at this kind of oblique angle to it. And as a result, when you look at the image, this is the image that corresponds to 1, you'll see that the artery has this kind of oval shape to it. On the other hand, if you tilt the sensor so that now the plane goes perpendicular through the artery, now you see a nice round artery, kind of like what you'd expect. And related to this idea is this anisotropy. Anisotropy. Let's go with that. Hard words to pronounce. This is the idea that essentially some tissues are very sensitive to the angle of incidence. And so, if you change your angle of incidence just a little bit, they might become very clear, or they might disappear altogether. Bone is not very anisotropic, but say tendons typically are. So your ability to get a good look at a tendon often depends on your angle of incidence. And so this is kind of the art. The general process I follow when trying to identify structures is first, moving the sensor into place, getting the right view, either a short axis or long axis, depending on what I'm looking for. And then first identify the bony landmarks that are near the object you're looking for. Because those are fairly, like I said, they're not anisotropic. They're going to be fairly easy to identify. Then you kind of slowly adjust the angle of incidence until you see what you are looking for come into the sharpest view you possibly can. And this is one of those things that just takes a little bit of practice if you want to get good at it. So let's conclude here. Tips for a good stand. Make sure you're holding your scanner in the correct orientation, right? If you're going to do a long axis scan, indicator light towards the proximal side. If you're doing a short axis scan, make sure you're holding this light towards the lateral side. Look for that bone first. Remember, bone is always going to look like a thin hyperechoic line with a big anechoic shadow underneath it. So that's how you found the bone you're looking for. And then you adjust your angle of incidence to get the clearest image that you could possibly get. And that is the part that takes a little bit of practice. All right, so now that you have a basic understanding of how the ultrasound works, and from the last video, a sort of a basic understanding of DOA, in the last video, we're going to put it together and talk about, well, how do you go about actually assessing whether or not a person is at high risk for having DOA at any given moment. We'll see you in the next video.